The first video is going to be about low desire. This is probably the most important thing that you hear in your office, and sometimes it can be the most frustrating thing when you're trying to get out the door. But I will tell you that it is integral in any long-term relationship to have good desire, because without it, the sex life will fail, as will the relationship. Do you know that 43% of women have had sexual complaints throughout their lifetime, as well as 31% of men? So it's very common to experience this in your practice. When you're troubleshooting these patients, you're looking for different things that will target you to focus on what might be causing the problem in that patient. So let's talk about low desire. Desire involves three things: drive, expectation, and motivation. So when we talk about drive, it's all in your head. So when people say it's all in your head, they're probably right, because it's the neurotransmitters and the hormones that are integral in this part. The excitatory neurotransmitters are norepinephrine, dopamine by far. Dopamine's probably the one that gets us in the most trouble because we get high dopamine levels in the early phases of a relationship. Sex steroids, estrogen and testosterone, are both excitatory. Now, on the inhibitory side, there are things that are very common that we see in our patients. Serotonin is number one. And look at all the patients that are on serotonin medications. Opiates, another big inhibitory factor for sex. And a lot of our patients are on pain medications. Prolactin and GABA are both inhibitory as well. Prolactin being quite high in the nursing mother, so no surprise why the lactating woman may have a low sexual desire. Dr. Stan Althoff did a nice model for female sexual response called the biopsychosocial model that incorporated the four components of desire in women. It involves the biology, the psychology, the interpersonal portion, and the sociocultural. So let's talk about sociocultural. This can be very specific to a culture or how any woman is brought up by her parents. So if your mother told you never look at the penis directly with the lights on and only pull up that nightie in the dark enough for him to get in, then your whole idea of sex will be very different from the girl who's used to nudity in her home, will walk by the sliding glass door completely naked and have no problem with that. Parents deliver messages that often last a lifetime. I constantly tell parents of young girls, please watch your messaging. While the parents interested in preventing their girls from getting pregnant too early and they want them to focus on their career, unfortunately the negative messaging can be long lasting. So really we have to focus on that. Lots of messaging about dirty and bad are focused in the genitalia. So lots of people get hung up about oral sex or any kind of manual stimulation or even masturbation for that regard. So these are all sociocultural influences on our sexuality. Let's talk about the biology. Doctors are very good with that. We just went over the hormones and neurotransmitters that are key. But the other focuses are medications that we prescribe for high blood pressure, medications for mood, medications for sleep. All of those have influences on your patient's sexual function. So we'll be going over each of these and how they affect your patient's sexual desire and sexual response when we're in the actual classroom. The interpersonal, I think, is the most important because that's how we relate to each other. If there's one thing that I tell everyone, it's mutual respect. You must respect your mate for whatever they bring to the relationship. People fall into the rut of saying, well, I worked all day and what did you do? You sat home with the kids and you didn't pick up my dry cleaning. If you do that, you are not going to get sex. So mutual respect. Another good scenario that I like to use is the working busy woman who's fed the kids, gotten the lunch together, and now she's on her third load of laundry before she goes out the door to work. And here she is bending over, picking out the laundry to fold in a cute little thong and bra, and her husband comes by and smacks her on the butt and says, "You going to give me a little bit of that later?" That is going to be a big heck no. That is the wrong approach to that busy lady. Now let's rewind that a minute and say, how could that interpersonal encounter have changed? How about if he approached his busy wife who's getting ready for her work day, fed the kids, done the laundry, and so forth, and he approaches this. First thing, bend down and start folding that laundry with her. Women love help with the housework. While you're folding that laundry, you look at her and say, wow, you look so sexy in that bra and panties. I'm going to have that image in my head all day. You've asked for nothing. You've complimented her on how she looked because she was feeling a little fat and bloated that day. And she is now thinking, he's helped me. He recognizes I'm working hard. Some simple little things like that can last a lifetime in a woman's memory. Women withhold sex for punishment all the time. I don't recommend it, but it is very effective. So while I counsel women not to do that, the interpersonal relationship is crucial. The psychology of sex is also important, and that is all of the other influences: anxiety disorders, depression, fibromyalgia. Within a women's lifetime, 70% of us will experience some kind of mood disorder. So no surprise that not only the mood disorder, but how we manage the mood disorder can influence a woman's low desire. So when you're thinking about the mood disorder, don't quickly blame it on the medication she's on, even though I've just discussed with you that she has had problems with taking serotonin medications. Is it the mood or the med? Is it an undertreated or inadequately treated anxiety or depression, or is it a side effect of the medication? A good history will give you that information. So simply ask, when did it start? If she's been on the medication for 3 years and then started having orgasm dysfunction, maybe not. Primary anorgasmia, which we sometimes see, is an anxiety disorder. So we may focus on a particular thing like vaginismus or anxiety disorder as a real problem that's more the psychology and not the low desire. So when the patient is coming to your office and she says, I have low desire, I want to know a little bit more. I want to know how long it's been going on, and I want to try and figure out, is it the psychology? Is it the biology? Is it the sociocultural? Is it the interpersonal? And I assure you, it's almost always going to be a mixture of all of it. The patient will force you in the direction of where she wants you to focus, but I need you to keep an open mind and think about each component and briefly go over. So in closing on this brief video, I'm going to tell you that I don't think women have low desire. I think they have low desire for the sex they are having. So when you're thinking about this patient, find out about that sex she's having, and let's see if we can make her day a bit better, because great sex is important for a lifetime.